Hello, everyone, and welcome to this May 22nd Screenside Chat with Children with Diabetes and Provention Bio. I'm Marissa Town.
I'm Diana Miller.
And tonight we're doing a little bit of a different format. We're pretty excited for it. So what we're going to do is first we're going to play a video that's a recording of Dr. Miller and myself going through a bunch of different questions and answers related to type 1 screening. And then at the end, we're going to do a live question and answer session and get to mingle a little bit more with everybody that logs in. So I don't know if you want to say anything else before we get started, Diana?
No, just excited to have a nice discussion at the end. So yeah, we'll get started.
Yeah, and so if you want to keep your camera on, you can. You're going to get tiny. We'll probably turn our cameras off so you can watch the video because it's going to be weird for us to watch ourselves. But please feel free to type any questions throughout in the chat. And if we don't answer it in the video, we'll make sure to answer it at the end. So with that, I'm going to share my screen and start the video. Hello and welcome to Screenside Chat with Provention Bio's Dr. Diana Miller and myself, Marissa Town. So I'm going to give you a little bit of my background before we get into this. I am a person living with type 1 diabetes for almost 33 years. I am a nurse and a diabetes educator, which has a new fancy name now. And I really went into working in diabetes to help other people. I learned early on how helpful having enough knowledge and having enough support really makes a difference in your life as a person with diabetes. And I'm privileged to work at Children with Diabetes as clinical director. And Dr. Miller.
Thanks for having me, Marissa. It's such a pleasure to be with you and to be able to speak about something I'm very passionate about and get information on such an important topic out to all these amazing families. So I am, as you mentioned, a doctor. I'm a pediatric endocrinologist. So I did my training in pediatrics and then specialized to become a pediatric endocrinologist. I found my way there because I was diagnosed when I was a little kid, coming up close to 30 years myself as a person with diabetes, and found that it was just an incredible thing to be able to see something from another person's perspective that you've seen intimately growing up as well. So, and to just be able to give back. And I tell people, I think of myself like a teacher, and I know that you do as well, being a formal diabetes educator. And so endocrinology is one of those fields where you get to teach, and mostly we think and we talk and we learn together. And it's a privilege to be here. My why is actually all the families that I've met through the many years that I've been in the type 1 diabetes space or endocrine space. And I'm sure we'll talk more about this, but being a mom of two girls who are genetically at risk themselves for type 1 diabetes motivates me greatly as well. So I'm glad to be here.
Yeah, absolutely. I completely agree. And I think it's really amazing to have the perspective and empathy to share with your patients. And I think we all learn from each other. That diabetes is not something that is very simple at all, as we're going to discuss today. And, it's very individual, it's very gray area. And, I find myself learning new things all the time.
Incredible. Yeah, it's the best teacher, and it keeps you honest, right?
Yes. Keeps you flexible and on your toes, that's for sure. It gives us some skills we weren't quite sure, we didn't quite ask for maybe.
Experts in resilience, yes.
Yes, exactly. Well, let's get into the discussion today. So today we want to talk about understanding, early screening for type 1 diabetes. And, I looked into this to try to figure out when the stages of type 1 were even, sort of formalized. And I believe it was in the last 10 years. Is that correct?
Yeah, so it was really 2015 that all these major organizations came together, the American Diabetes Association, Jdrf, Endocrine Society, all these incredible thought leaders put their heads together, and they're like, wow, look at what we've learned from these decades of studying the natural history of type 1 diabetes, there's actually a preclinical phase, meaning there's no symptoms, but that process is ongoing in the background, and it lends itself to what we have right now, which is 3 main stages of type 1 diabetes. And if you want, I'm happy to walk through them just so we can understand them a little bit better.
I think that would be helpful. Yeah. And I think it's interesting because I think, as we have things like autism, where we sort of, as the medical community or, fellow humans, have decided this is more of a spectrum, I kind of see the diagnoses of type 1 being similar, where some people have like very rapid onset, they're in severe DKA, and other people are like just hanging out for a little while.
Lead their way in. It's so true. It is such an incredibly, the word we like to use in the medical community is heterogeneous, right? Like it's just like a fancy word for like, it's a mixed bag. So, sometimes, just like you said, it's fast and furious. Like you almost can't wrap your head around it as a concept or as a parent before your child is really sick with diabetic ketoacidosis in stage 3, which is, what we're all used to defining as clinical diabetes, where you need insulin to stay alive. You present with, the increased thirst, the increased urination, the weight loss, the vomiting, the altered mental status, the electrolyte derangement, right? Lands you in the ICU. It's a really unpleasant way to walk into this diagnosis. And so that's why people set out to understand the natural history of the disease, because they're like, wait a minute, we have a runway. And learning in this process that not everyone comes to the diagnosis of stage 3 diabetes in the same exact way. Some people really do like wander their way through stage 1, stage 2, stage 3 at a leisurely rate. And when they arrive there, it's a different clinical disease than it feels for some people that just kind of, like me, fell flat on their face in DKA and ended up in the ICU. So, but understanding the science gives us so much power, right? And that knowledge is key. And I don't think, correct me if I'm wrong, but I don't think very many people realize that there's these defined stages and that there's a way to actually put people into stages, right? And to stage them and to see where they are.
I think this is because it's newer. And, like you said, just in 2015, so 7 years ago, this came out as a consensus concept, right?
Yeah.
I mean, and especially for those of us that were diagnosed 30 years ago, yeah. I mean, there's no way that we would have heard about this.
Pick our stage. I know.
Yeah, exactly. We're already there.
Yeah.
So I would love to hear more about how do you identify like type 1 in the earlier stages, in stage 1 and stage 2?
Perfect. Yeah. So stage 1, and this will, I'll use the correlate of when, families came to the diagnosis of stage 3, we confirmed it, right? A lot of people remember doctors saying something like, oh, we're sending some blood work to confirm that you have diabetes. And you're like, wait a minute, I have diabetes. But what they meant was those autoantibodies, right, that are floating in the blood. And those are, like specific tests that tell you that the immune system is targeting, parts of the cells, the beta cells that are making insulin. There's specific proteins within the beta cells, right? And the immune system makes these B cells, make these little pinchers, the antibodies that normally help us with viruses and other things, right? But they're targeting the wrong thing. And it's like a flag that this process is ongoing and burning in the background. So stage 1 is before you have any changes in your blood sugar, right? You have a lot of those healthy beta cells around, but those flags are there, those autoantibodies are there. So there's, really 4 main ones that we can send. There's an older version that's fallen out of favor, but there's really 4 main autoantibodies that we typically send. And those can be done, like I said, through blood work. And when you have 2 or more of those, and there's some nuance to the science here because we're sort of learning about, people who may not fit, like I said, it's heterogeneous, right? So may not fit that perfect picture of 2 or more, but what we know is that the people who have persistence of those autoantibodies fit into stage 1, which is where you said you're on that path, right? Like you've declared yourself, you're walking your way towards a diagnosis of what we know as clinical diabetes. And the next stage 2 is where you start to see enough of those beta cells get unhealthy or not work as well or be killed off, that then you start to see that the body can't buffer as much, right? And so you start to see those, what we call dysglycemia or some abnormal sugars. Like if we were to put a CGM on you, you do things that like we go, I don't know that you're supposed to go up that high and come back down, but it's not yet enough where we're going, aha, this is clinical diabetes, or not yet necessarily enough to see any symptoms. So that's stage 2. You have the autoantibodies, and then you have what we call dysglycemia, or those abnormal blood sugars, but not yet hyperglycemia or the formal definition of stage 3 diabetes, which we're all really familiar with, the criteria for that. And certainly it helps, right? Anytime you have signs and symptoms, it makes the diagnosis a lot easier. Although we all know, sometimes even that isn't enough to help us kind of realize what we're dealing with. But yeah, we've defined those 3 stages. And just like you said, everyone goes through them differently. And that's what makes this all so tricky, because you don't know where you're going to find someone when you look, or where you're going to meet them, and how fast they're going to walk on that path.
Right. Absolutely. It's a good thing this isn't really complicated.
No, right? I know. Wouldn't it be nice if you could just like roll in with all the answers, like start your, like, here's your book, here's on page whatever. I know that's not how it works, but the good news is we can go through it together. So.
Yeah. And so now that the endocrinology field, at least at large, and us people with diabetes, know that there are these stages.
Yeah.
What exactly does the screening process look like?
Yeah, that's a great question. So, for years and years and years, hooray, like how we came to the science of diabetes, it was research, right? TrialNet, for example, in the US is like, and it still is one of the best ways to find out your risk for type 1 diabetes. They set out on, this quest really to find people who were at risk of developing stage 3 diabetes, pretty much with, 2 main goals, right? One was to understand the natural history of the disease. The other was to figure out, is there something we can do about it? And that quest is still ongoing. But the other way is, totally valid. You could just go to your doctor's office and say, hey, I have a family history of diabetes. And if you look at, for example, the American Diabetes Association Standards of Care, right? Like just this 2022 guidelines. In the child and adolescent section, there is a recommendation there that family members of those who have a diagnosis of type 1 diabetes can ask that question, can be screened, can be offered screening, right? And that's, like I said, those same tests that we send to confirm the diagnosis are the same ones that we send to ask that question. Are you on a path to developing stage 3 diabetes? And then, of course, other exciting sort of things pop up, new techniques, new science, new ways of answering this. We now have kits, for example, that are dried blood spots, right? So you could send in a blood spot and they run a very specific analysis and come up with the same answer. Are those autoantibodies floating around in the blood? For example, Jdrf has one of those kits available, and the cool thing about it is that people can answer that question outside of, finding a peds endo to go in and order in LabCorp request, the exact test. The tricky part of that is that then you can't turn around real quick and be like, hey, let's talk about this. So, so there's pluses and minuses to every way you want to answer that question. The good news is that there's options and it's talked about and they're available. So when people are ready, they can answer that question.
Yeah, and I know we've talked about this before, but we'll talk about it for the benefit of our audience. So I've had my son screened. I have a biological son and an adopted daughter, so she doesn't quite qualify. So usually my understanding is that it's first degree relatives. So what does that exactly include?
Yeah, so technically, I guess it depends who you ask on this question. So, and which section of guidelines you want to go to. So, so for children and right, I know nothing is easy. So for children and adolescents, it says any family member, right? So, and I think that that's important because parents forget this, but like those are genes that run in a family, and you can develop type 1 at any age. Many times have I had, families that have a kid with diabetes, and then like the parent goes on to develop diabetes themselves, or a sibling, right? And so this is one of the reasons why, again, it's who you ask, right? If you look in a different section of the guidelines, it does recommend, first degree relatives, but we sort of know that like that increased risk is really based on family history at large. So even second, third degree relatives, it's a 15-fold increase. The good news is that, over time, that risk does kind of go down towards the general population, but people have to remember that type 1 diabetes is like second most common chronic childhood diseases, right? So, it is fairly common, but the other thing to remember is that it's common, but it's still rare, So,
Right.
so when people go to look for it, it's not everyone's going to be on that path, and that's a wonderful thing. But we do know, of course, 90% of the people that join our tribe, right, had no family history, but had those genetic risk factors that sort of the stars aligned and put them on the path to joining our tribe. So yes, that's nuanced. It depends who you ask. You're going to get different answers depending on who you ask. I'm a pediatric endocrinologist, so I'm going to tell you, go ahead, screen people, because I think knowledge is power, right? So being able to answer things when you're ready for it, right? That's key. We'll talk about this, but when you're ready to cross that bridge, knowledge is power, and everything is better with time and preparation. Things rarely go as well when you're rushed and it blindsides you. So that's one of the reasons why, we're having this conversation.
Yeah, absolutely. And I think, it's got to be an individual choice, right? And, we can say, listen, this is what we recommend. But, I know other endocrinologists who haven't screened their own kids, and they have.
I'm one of them.
Yeah.
I'm one of them. I have their kits ready to go. I have it. And I always just told myself, when I'm just next week, I'll be ready. Right. But it's a big question to answer. It is. And what you do with that information. I sort of have that, and I know I interrupted you, so I apologize. I have that cavalier mindset where I'm I live with this. I know what we'll do. If we cross that bridge, we'll cross it. But it's a big thing to think about, right?
Yeah.
And good news is you can be on the other side of it, right?
Yes. Yeah. And that's what's I think I've had a great experience because our son did screen negative, and it did allow me to have just a little breath of relaxation, I'm just okay. I mean, does that mean that when he's peeing a lot and drinking a lot, I'm not poking his finger? No, of course I'm still going to do that because I'm hyper aware of the symptoms of type 1. He had a stomach bug and hadn't eaten in forever. And I was I'm just gonna, and he was 76. So
and you're I've never been so happy to see a 76 in my life. No,
exactly.
But it's true. And I will add to this, with scientific data, you can screen negative at a time point, and later you can turn positive. It's called seroconversion, right? And so when we look at some of these major natural history studies, giant European cohorts that screen the whole country in Germany or, in TrialNet, right? We looked at thousands of people. What we have learned is that in order to capture the most individuals who are on that path to developing clinical diabetes, there's really 2 or at least 3 time points that really pick up the most individuals. And that's around 2 to 3, 2 to 4, again, around kindergarten age, 5 to 7 age. And then maybe once again, kind of in that childhood school age. And those will pick up the most people. But I told you, it can happen at any time. And we don't have as much natural history data in adults. So we don't know as much about in your 50s, can you seroconvert and have those autoantibodies be there and then walk your way to clinical diabetes? That could happen, right? It's less common, but that could happen. And so you're right, a negative test feels like a glorious weight off your shoulders. But you have to be smart, right? And know the pitfalls of that data. It may not stay that way forever. Most likely it will, right? 95% of the time it will, right? But you have to have your wits about you, and people who are at increased risk, those of us with a family history, it could change. And so we need to sort of know that, because if something alerts us that perhaps we should ask that question again, we need to ask that question again. We don't want to rest on our laurels and have that false sense of reassurance, but at the same time, oh my gosh, if you could just get a little bit of right, can a stomach bug be a stomach bug? Yeah. Right. So just for however long that might be.
Yeah, and I think too, it used to be that TrialNet would screen people yearly, and I think because 95% of people don't seroconvert, they, for budgetary reasons, mostly, I believe, had to stop doing the annual screen, because we had Connor screened, he was 18 months, then 2.5, then 3.5, and then, the funding got changed, which is totally fine. But so that would be at that point. So let's say, so my kid's negative, right? And his blood sugars are always fine. Great. And he's 8 now, right? So is this a good time for me to maybe order one of those kits as opposed to doing like a serum blood draw?
Yeah. I mean, listen, as a pediatrician, we hate drawing blood. Like, we're like, how can I group everything that we ever need to do? Like get a crystal ball, like predict the future, try to just make this not a traumatic experience, right? Like we just want kids to not ever be afraid of going to the doctor or have a bad experience, right? Sometimes there's no way around it. So a kit's a nice option because, oh my gosh, like a finger poke versus a blood draw. Although I've had families say like, well, put on the numbing cream and like a blood draw is not so bad. Finger poke, I have to be held down and that's more scary, right? So like it's never one size fits all. And that's why having options is such a nice thing. But you're right. Like the data does show by the time you kind of make it to later childhood, if you haven't seroconverted, that risk goes way down, especially in the context of having a family history. It doesn't go to nothing because it doesn't go to nothing ever, right?
For anybody.
Yeah. But it does go way down. And you're right. Clinical trials are designed to meet endpoints, right? To understand knowledge, like very specific. If they had an unlimited budget, my gosh, I'm sure they'd be like, how many times can we screen every single person on the planet to understand this better, right? But it's not how it is. And the important thing is that we all as a community know that and know our options so that we feel empowered to ask those questions and find a way to get the answer that fits us the best. So.
Yeah. And so I would like to switch gears a little bit and talk about what happens if you are the parent or whoever and your child screens positive.
Yeah, that's a great question. So, so that I guess I think of it like this. Positive is positive, but there's a couple more question marks, right? So are you positive for one autoantibody? I just told you the definition was 2 or more, but we know that some people have one and it persists and they still progress. That will blow everyone's mind, right? But we also know that you could have a 1 positive autoantibody and go back to 0 and your risk goes way, way down. We know that most people that are going to go from 1 to multi-positive tend to do this within 2 years. So, reason to find an endocrinologist or a pediatrician or a provider, right, that has that expertise, that's willing to sort of walk that walk with you and answer that question or be part of a clinical trial where it's actually going to be built in, right? Because that monitoring process is what gives us those answers. Obviously, if you're positive, you want to confirm it or to have a discussion, right, with someone who understands that science, right? And then the question is like, which stage are you in? Which is looking for that dysglycemia piece, because you could be in stage 1 and you could stay there for a really long time. But once we know that you have dysglycemia, meaning the sugars are not quite normal, that is our sign that things are going to progress on a timeline. And so that dysglycemia is really important for us as medical providers to understand, because we go, like I need to watch this one a little bit more closely, figure out how with the family do we monitor them.
And what kind of monitoring do you typically do as a pediatric endocrinologist that might be a little bit different from what a pediatrician would do?
Yeah. So, pediatric endocrinology, we love what we call our STEM tests, right? So, but we don't love them because kids don't love them. But all the major studies do something called an oral glucose tolerance test, which when I tell you about this, it like sounds kind of fun, but then you're like, ugh, it sounds kind of gross. It's like chug as much sugar in a drink as you can in a very short amount of time, and then we'll follow your glucose in time increments and see where it goes. Some people look pretty green after trying to chug that much glucose, and the blood draws are not fun, right? So, but this is how we got our major data to understand the science here. That is a valid way of staging people. We can look at the glucose, see how they respond to a stimulation or an oral glucose load. And that gives us information about stage 2 versus stage 3. We all kind of know living with diabetes because it's like, look, we're both moms. Like that meter comes out the minute our kid like looks at us cross-eyed. Right? So my kids have had their fair share of finger sticks. They kind of like, you're just like, here, mommy, I know you're going to want this, you know? But, a finger stick is a valid way at home, right? To get that information. May not be enough to necessarily hang your hat on a diagnostic criteria unless it's like, obviously elevated. But the other way would be new data that we're learning about. Again, these major studies have all these incredible people going, geez, I wonder if we can predict stage 3 using a continuous glucose monitor. If we put a CGM on kids in early stage diabetes, do they look different on their glucose tracings? Do they stay above a certain, glucose for a longer period of time, or do they show more variability? All these questions, we don't have the answers perfectly yet, but we're learning that that we can get those answers. And so you might find an endocrinologist like me, like I might give you a prescription, see if we'll get it covered to, put a CGM on.
Right.
It will give you peace of mind, or it may not. Like I have some families, that are like, no, like this is too information overload,
It's
right?
a lot of information.
Yes. And so again, I think we'll learn this as we walk into to a brave new world, but it's not going to be one size fits all.
No, it never is. And then, do you think, hold on, sorry, my dog. Hold on, let me pause it. So when do you think it's best to go to your pediatrician? Like, do you think if you're a family and your kid screens positive and you go to the pediatrician, what would they do? Do you think they would give you a referral if they're uncomfortable, or would they do an oral glucose tolerance test?
Yeah, so you're getting me back onto the original question. I guess I got so excited about talking about stim testing that I was like, oh my gosh, let me just talk about like a million ways that I would think to monitor glucose. But it's true. So pediatricians probably know about this information, but don't do this day in and day out the way pediatric endocrinologists do, right? So they probably would prescribe a glucometer at the very least and talk about signs and symptoms. I think a lot of pediatricians would say, kind of just knowing that there's only a couple hundred pediatric endocrinologists in the US practicing, like, let's get you a referral over, because it might take a minute to go see a pediatric endocrinologist and have this conversation. The truth is that I would encourage everyone to be on the same page and everyone to have these conversations, because this is a journey, right? So you're going to need places of support, someone to bounce some medical information off of, someone who knows your family, who knows your family's temperament, how you cope, right? How you adjust to things. Like you want people that understand the science to walk with you on this. And so, yeah, you might have a superstar pediatrician. I will tell you, most of my screening conversations actually were with my pediatrician before we moved, to the South, up in Western New York. Every single well child check, she'd be like, "Are you ready? Do you want to know?" Like, I think she wanted to know, right? I was like, but I could tell you are. But the truth is that, when you're ready, right? So having that conversation is important. And yes, the answer of how you screen, and if you screen positive, who's going to do what, I think it's going to be region specific, right? So some places in the US, it's a long drive to a pediatric endocrinologist. So someone talking to your pediatrician about what they might order, what they might do, and just providing that guidance. The pediatrician will probably do that. Some places it's like, you're lucky. You can just like pick which office you want to go to, and there might only be like a 2-week wait. You can get right in, and you might get right into a pediatric endocrinologist to talk about it. But the key again is to establish that relationship, to do it in partnership with someone who understands the science and supports you, gets you and supports you.
Yeah, and we have a neighbor who their son was diagnosed in DKA, had all the symptoms, had a pretty awful time. He also got COVID while he was in the hospital with DKA because, of course, I know this poor kid. And the parents, they went to the local children's hospital and they were like, yes, we're going to screen all of our kids. Okay. And they had 4 kids, and another one came up with 3 positive antibodies. And so, the next thing I want to ask you is something that I wish I had been able to ask you before all of this happened, because she was, this poor mom is like, how do I talk to my daughter who watched her little brother go through this horrible experience with these positive antibodies and not, balance the, hey, this is probably going to happen with the, oh my God, I'm freaking out because, I'm 10 or 11, I'm a tween girl and I don't want to have to go through, what my brother went through. So what tips would you give for parents in navigating those conversations?
So the first thing I'm going to say is, half of all of our new onsets are diagnosed in DKA right now. That's too high, right? And this is why we're having this conversation, because we know there's a runway, right? And catching people earlier avoids the trauma. I mean, that's trauma. Being admitted to the ICU, being the sibling of a child, watching your brother or your sister go through something where they're really sick and it's scary. But for the parents, it's really scary. We should avoid that at all costs, right? And so that conversation isn't easy. And I'm going to sound like I'm hedging here, right? Because every family is different. And each child goes through different developmental stages. Like, I wouldn't expect a 4-year-old to be able to understand things, although some of the most brilliant people on this planet are the 4-year-olds that just radically accept things, right? Yeah. Just yes, I get one of those book bags. I remember my girls being like, if I got diabetes, Mom, it wouldn't be so bad because I'd have a cute bag like you have a cute bag, and I'd have all my diabetes supplies in it. I was like, I love you so much. There's so much more to that. But we had those conversations, right? And then there are some families that know their kids very well. Like my older kiddo, she worries. She's a worrier. She's really smart. Sometimes I have to give her more information so she can understand risk and put it into perspective, like a little adult. And sometimes I sort of just know what I can't say, or it will unsettle her. I think in that family's case, it's really important to point out that that diagnosis story is going to be totally different than the diagnosis story of what his or her sibling went through, because they found it before they got so sick. And, kind of what we know is that every beta cell counts. Yeah. I mean, I know that sounds like kind of like a silly slogan, but picking it up earlier means if you have, even in clinical diabetes, if you can achieve glucose control, more readily, like that might prolong a honeymoon period, right? That might make it a little bit easier. So for that family, there's a reason to be hopeful, even though it's incredibly difficult to be rendered a diagnosis, potentially when you don't even have symptoms, but that knowledge is power, right? There's the opportunity for clinical trials. There's the opportunity to avoid what happened to your sibling. There's the opportunity to have that shared connection, to be part of an incredible community of individuals who are just amazing, living with us day in and day out. I think it wouldn't be wrong necessarily for a family to take a different approach with each kid. Like, even within a family, right? Like, each kid copes differently. Each kid handles news differently. Like, do you slowly wade them into it? Do you tell them all the information right up front? Everyone's different. Pediatric psychologists, so a lot of diabetes centers have them, and they're a phenomenal resource. And they would be basically the experts, right? And how do children wrap their head around really big, new sort of scary things, right? And how do we wade them into that and help them cope and adjust? And even in a family dynamic, there's so much guilt, right? You and I are lucky at the moment that we don't have a child that has type 1 like us, but the guilt that you carry, that it could be a possibility or that you need that one day, that's something that sometimes you need to talk to someone to get that outside perspective on. So the easy answer is there's no right way. But I'm a believer that knowledge is power. Like you, as an educator, I'm the kind of person that needs to know everything I can on a topic, and that gives me peace of mind. There are some people that want to know exactly what they need to know at the right moment, and either way is okay.
Yeah, no, absolutely. Yeah, and I'm definitely more of that. Yeah, give me all the information, and then I at least feel, I don't know, a little bit better. I don't know.
Well, there's options. Knowledge is power.
Yeah.
We kid around, internally in our meetings at Provention, but I always say what situation have you ever been in where time and more information doesn't help you be well prepared, right? There's just no scenario in life where you have to deal with some big emotions, right? Anytime you cross something that makes you think really hard like that. But knowing ahead of time before you're in the middle of the ICU, learning how to be your own pancreas. Like there's power there, and have the chance to at least have a conversation about how will your diagnosis be, and how will that happen. So.
Yeah. And I think, you touched on something that I'd like to ask you to dig a little deeper on is, every beta cell matters, which RIP to our beta cells. Could you talk a little bit about, and I know some of the studies, but, from my understanding, it's the more residual beta cells that you have, the more protected you are from both acute and chronic complications.
Yeah. So it's interesting because there's no gosh, don't you wish that we could just do this randomized study where we just take people and we just know exactly the number and correlate it to long-term outcomes. So the best we can do is we can take groups of people and look at aggregate data. One of the best studies that we're sort of clued into, that tight glycemic control makes a difference in a long-term in our risk factors, right, for complications. And this is the best probably analogy that we have to answering this question of does having the ability to produce your own insulin make a difference, right? So the DCCT took a group of people and they had them in really tight control, right, for those first couple of years that they were diagnosed. And then study finished and funding went away and people went back to, they all converged and they all had about the same control. But then they followed them for a long time. And they looked at those complications. What they found is that the people who were really tightly controlled, it's almost like cells hold a grudge, right? So the people that were really tightly controlled, their bodies, they developed complications at way lower rates, even if their control later kind of went back to everyone. Everyone kind of did the same thing. The people that had not so great control in the beginning, and then were oh, I gotta get this together, and had a really tight control, and then maybe went back, they didn't see that reduction in the risk of complications. So there is something to those first couple of years after you're diagnosed, and your ability to maintain that glucose control. I mean, within reason, you have to stay sane. I'm not saying here please let's all just flatline it. I won't even name numbers. But you know what I'm saying?
Yeah.
But the best you can do, right, to maintain that less metabolic derangement for your body, right, that potentially sets you on a trajectory that changes the disease course. That is profound information. Now there's always the question of the chicken or the egg. Yeah. Right. And I won't get into that because we don't know. We don't know that yet. But what we do know is that anything that can make it easier, right? And we all remember, those of us who've lived with type 1 diabetes, what that honeymoon period was like. And some of us blissfully, not me, I'm in that low C-peptide range where I earn every day of yay, time in range. But where it felt like it was easier, right? Where diabetes felt like it was easier. So that might be that every beta cell counts, right? So yeah, I think that concept isn't something that you learn about until you've lived with diabetes for a really long time. And it's something that we owe all of the families that meet us whatever stage they're on. But if they're in a path to this, every amount of effort they put in isn't wasted. That's how. Yeah,
and I would say, that I know there are a lot of studies that are looking at, getting kids on closed loop right when they're diagnosed, getting on CGM right when they're diagnosed, using all the tools that we have to achieve glycemic control where it is less difficult, with all the injections. And not that everyone can do it, and everyone wants to. Some people, like you said, CGM gives you a lot of information, and you have to be able to intake that kind of information.
Process it. I know. What other disease requires you to make 200 or more decisions a day, process so many different variables? It's that burden that we talk about, right? That's there. But and everyone, some people are ready for the burden and won't ever put it down. Some people need lift it for a minute, high intensity interval training, and put it down and take a rest.
Oh man, that's a great example. That's like pregnancy.
Feels like something. That was what pregnancy felt like for me. It was it's just okay, let me hold this boulder for 9 months and then put it down. But
what a fun time.
Yes. But we could do a whole nother hour just on but it is true. I think what I really want, us to be able to convey together is that like whatever effort you put in isn't wasted. It's not wasted. It makes a difference. Some days it feels like, oh, like you've done it all right and it didn't go the way you wanted to. And some days you're like, yes, I won. But the key is to just keep going and to know that every effort you put in makes a difference. And truly, I don't know how you feel, but I feel like just the last decade of where we are going, where we have come from, where we have been, there's a lot to be excited about. So yeah, I think as hard as it is, we're finding ways to lighten that load and to lift that burden a little bit. And there's a reason to be really hopeful. So.
Yeah, no, absolutely. I completely agree. I think, no better time to be diagnosed,
Never a good time, but if you had to pick one, it's better now.
Exactly. I mean, and I'm glad I don't remember like the urine, I didn't have to do urine testing. They had, home glucose monitoring by the time I was diagnosed in 1989.
Like a count like a minute long, like
yeah,
family event.
Big drop. Yes.
Yeah.
Exactly. But I mean, my dad who founded Children with Diabetes, he always talks about Dr. Elliot Joslin, and he was one of like the founding endocrinologists for diabetes, back in the early 1900s. And one of the things that he's, prized with saying is the person with diabetes who knows the most lives the longest.
It's so true. I mean, it sounds so simple, right? But it applies to really everything in life, but every chronic condition where you are the driver, you're the captain of your own ship, right? So the more you understand, the more you know for your family. I mean, you see it differently. You learn better. You have more tools in your toolbox, right?
I use that same expression.
Yes, it's true, right? Like we have to fill up every year. Maybe we get more new tools, but we have to keep learning how to use them, refining them, adding to them. And I want to add this too, like the people that you walk with on this journey, and like you, Marissa, one of my dia buddies now. Yeah. Yeah, like that make a huge difference in how that experience feels, because there is nothing worse than going through something hard and not feeling like you have people like there at your back, right? And so as we meet people in screening, they need a sense of community, right? Because all of us are kind of like, I'm in the DKA club. Like I fell flat on my face, and there's a whole bunch of other people that had that same story. As we find people earlier and earlier, their story is going to be different. But that doesn't mean that they don't need a tribe of people to support them and to kind of walk that with them. And that's why I love, hopefully, like this conversation that we're having today prompts people to share their experience of their questions around screening, why they did or they didn't, how that went, have that support for each other, because that's almost as important as all the new tools and tricks and all the exciting things we put in our toolbox. But that tribe matters a lot.
It does. Yeah. I think, having someone that you can text when, I don't know, like my infusion set almost ripped out like 20 minutes before we started this and got caught on a handle. And I was like, oh, really? Having someone that you can talk to about that kind of stuff, getting fish hooked by your pump tubing.
Oh my gosh. Yes. Like a quarterly event and the shriek is like heard down the hall, like the neighborhoods are,
I know. And it's not even, it doesn't hurt. It's just annoying. Okay.
Like, I just put that one in. It was working so well. I know.
That is, I think that's something, and that's what CWD strives to do, right? To give everybody not only the knowledge and the education from, important people in the diabetes community like yourself, but also meeting other families so that, the parents can talk to each other about their challenges, so that the siblings can talk about how their sister tries to get out of chores with low blood sugars. Not that I would know.
Wow, I like that. I have to maybe think about how I could stack the cards in my favor. I'm kidding. I hate your blood.
I know, right? Like, oh, sweetie, I'm low. Yeah. But all those conversations, yeah, they They really make a difference. And I'm just so excited that we have this ability to screen people more easily, that it's not always, having this online kit that you can order. I just think it makes it so accessible, I think, for people.
It does. And it opens a conversation that like a lot of us we didn't get a chance. No. We didn't have a chance. Now there's a choice. You don't have to screen, right? Like there is nothing that says you have to. You can wait until you need to face that problem. For a lot of us, like me and you, who like love information, I would have loved to have known about this. My parents would have loved to have known about this. The fact that we're at this point where we have options, and it's in the standards of care, like that's rewriting the history of our disease, right? That's exciting stuff. So yeah. I don't know if we can like take away one thing from like our chat is like, I probably confused all of you more, but the good news is that smart people have written it out into like infographics that make it much more clear. Like resources, your CWD website, right? Great place for information. TrialNet, great place for information. Jdrf, great place. EDA, great place. Like there's just so many, and each other. Like there's so many great places for information, and they won't give you the like convoluted textbook of like, well, it depends.
Yeah, but that's the reality, and I think what's nice is I hope that also people feel, like we give you permission to, have all of the different feelings about screening that you want, and to remind yourself and have some compassion for yourself that, diabetes is never perfect. Like, both of us are trained healthcare professionals working in diabetes, and we do not get it perfect every day. No. It'd be great.
You hear my alarm? I like miscounted. Yeah. My lunch, I'm like, oh, I'm not too high, but I'm like sitting here like anyone with diabetes is going to know Dr. Miller's alarming on this call. That's okay.
Yeah.
We are not perfect. We are living. So
exactly. Well, thank you so much. This was spectacular, and I'm really looking forward to our Q&A session. So
I know we're going to learn a whole bunch more, which is the best part of all of this. So
exactly.
Yeah. Thanks, Marissa, for this chat, and I just. Anything that people can do to arm themselves with knowledge and have that conversation, go after it with the degree that makes you happy. So,
absolutely. Thank you so much,
Thanks
Dr.
again. Thanks for having me.
Absolutely. Well, hello. So thanks to everyone who stayed on the whole time. Really appreciate it. And I'm really excited because people definitely already asked questions in the chat. So I want to go to the first question, and, I want to offer up, Amanda, if you wanted to unmute and ask your question, you're welcome to, but you don't have to.
Sure. I think the first one was about my son or myself. I think the first one's about myself. So my daughter was diagnosed with type 1 in August of 2020. So at that time, both my husband and I did TrialNet. My son was too young at the time. You have to be 2.5. Mm-hmm. So when we did TrialNet, we were both negative. And so that August of 2020, and then October of 2021, I got type 1 diabetes. So I know that you spoke in, the recording that it's not a definite no, but I just think it's so interesting that it was a negative. And then just in that 1 year of time, I was 36 when it happened, that it shifted. And I just wanted to hear more about that shift that can happen and how quickly, because once you answer that question, then I'll go into my son, who also has some stuff going on. Because, like you said, getting that negative is kind of a relief, but now that I know that the negative can quickly become a positive, I just wanted to hear more of your thoughts on that.
Yeah. I mean, I will say, of course, the statistics say that's rare, right? And that's why the trial was designed the way it was designed, right? They were really sort of refining the data, looking through, realizing that most people that screen negative, especially at that stage in life, are likely to stay that way the majority of the time. But there's a false sense of reassurance, which is why that counseling piece is important, because not every test, I think I said this on the recording, or I say this all the time, not every test is perfect, right? So every test that you do as a screening test has what we call a sensitivity, meaning its ability to detect something. So you might have been truly negative It may also have been that the test itself missed a low level of positivity, and then that process, for whatever reason, really increased. And had you been rescreened in a certain interval of time, maybe it would have been a different result. We can't say that for certain, but that is always one of the things that we worry about when we send a screening test. We want it to be very sensitive because we want to pick up everyone who's at risk, and then sort of take that information and decide what's the right intensity with which we need to continue to follow people. In the setting of a clinical trial, it's not the same as clinical practice, where once you know information, you want to do everything in your power to achieve a good outcome for that patient. It's a protocol. So it's set in stone. They can't change it. And that's where Marissa and I talked a lot about options, right? Because before, there was really not much you could do. There weren't kits you could order. It really wasn't very common to go and get phlebotomy at your doctor's office with these tests, because people just didn't necessarily know which ones to order. And so you are a perfect example of why we need options, right? Because you might have maybe noticed symptoms and gone back and had that conversation a little bit earlier. Not that it would have changed the outcome necessarily for you, but it's just, you probably had that false sense of reassurance where you were like, I'm good. I never have to worry about this again. And you're like, what? They told me I was good. I'm not good. So that's so frustrating, but thank goodness you knew, so, and I won't put you on the spot and make you share your symptoms, but I wonder if the way you were diagnosed, because you were so knowledgeable at that point based on your other child, helped you in a way. Whereas if you hadn't known, you might have been blindsided. Like a lot of adults get diagnosed and are misdiagnosed or miscategorized as type 2 diabetes and sent home not on insulin, right? And that potentially can be life-threatening. So in a way, your child's diagnosis helped you not suffer a potentially very bad outcome, but still very frustrating that happens. And, we talked about the different assays, right? And so that the Jdrf kit, and I think there was someone else who had a question about that, but the Jdrf, is it you? Okay. Go ahead and I'll let you ask that if you want, and then I'll dive into the
okay, sure.
details there.
And actually, I didn't have symptoms. I was diagnosed because I threw on my daughter's expiring transmitter to see what my blood sugar was like.
Yeah.
And first blood sugar reading was 190, and then I ate dinner and I was 300. So I fortunately knew what that meant for myself.
Yep.
So when I was diagnosed, my A1C was only 6.4.
Wow.
But it's because of the year that I had of her that I knew what to do and how to do it and those things.
Yep.
But my second question is about the tests, actually, the assays that they do. So when my son finally hit 2.5, they tested his A1C, which had been rising.
Okay.
And that was kind of strange for the pediatrician, because she's like, we don't usually test A1C, 2.5-year-olds. And he was negative on T1 Detect. So again, kind of sigh of relief. But while I was waiting to see an endo for myself, it was actually very challenging to find an endo to see me when I knew I had type 1 diabetes, because no one believed me. They all thought I was type 2.
Oh, geez. See?
It was actually kind of scary how little I could get in touch with people. And so I ordered the T1 Detect in the meantime, just to prove, right, to have that information prove.
Smart.
Then I contacted my daughter's pediatric endocrinologist, who called in a favor with my Dexcom data. And so I didn't need the T1 Detect that I had. So I called and I was like, can I just use it on my son? Like I know it's in my name. So 6 months after his trial that was negative, we did T1 Detect and it came back positive. It was positive for the insulin autoantibody. And so now there's these two, which I imagine are measuring the same things.
Yep, but a different technique.
Different technique and different results. So now it's like, how do I like breathe again to know that I've kind of have that sigh of relief? But so it was my daughter, 14 months later, it was me. So I'm just wondering, how are they, and how often does that happen where one test says positive, one says negative?
Well, so I'll try to answer. I'm going to confuse you more. I'm going to teach you some more science, and then we'll try to back it up. I always give confusing answers, but so it's a different technique, right? So the way that the TrialNet assays were done, depending on what year this was that you were screened, some of them are less sensitive, but extremely specific. So if they're positive, they're positive. Some of the kits are very sensitive. So you're going to pick something up at a very low level right? And it may not stay at a low level. It may progress. It may revert and go back to nothing. Or it may just be an indication that then in a couple of years, you're going to screen positive if you redid the trial net, or a couple months in your family's case, right? Because you guys seem like you progress quick. But then if you did the trial net kit again at a later date, maybe it would be enough to be detected. And then in that case, it would be positive. So it's hard to say. This is why I say the word persistence all the time, because one individual test, I mean, granted, if the whole panel is positive and your sugars are higher, you have type 1. What stage you're in depends on how high the sugars are. It's stage 2 or stage 3. But if you have just one antibody positive and it's only picked up on the really sensitive assay, but not necessarily on the one that's very specific, but not quite as sensitive, hard to say. And you need to be followed. And so that's why we talk about this a lot. You need someone who kind of understands that science, that can walk with you, because in your case, for your son, it may be something, but it may not. Time is going to tell us that. So if he has that antibody positive and positive later, and then develops higher sugars, that's a pretty good indication that he's going to end up with stage 3 diabetes. If he has that kit be positive and then you repeat it again in 6 months and it's negative again, you don't know. That's a much lower risk, but you just don't know. And so that's why, you're smart to ask these questions and to sort of be persistent about it, because I think most of us don't know that any of this is something we can look at, right? The general population has no idea that there's these earlier stages and that it can wax and wane. It can progress at different rates in different families and in different people. So a lot of that is just not common knowledge. And that's why you're kind of sometimes going to get like a cross-eyed look when you're like, should we test again now? Should we test again in 6 months? And the truth is that the science is evolving as we're figuring it out, right? So all of these new kits have only been around for, less than 2 years. So the older assays that we use to diagnose people in stage 3 have been around for a long time, many, many years. But some of these techniques now that we know, they're really good tests, they're very sensitive, they pick things up. We haven't had them to play with in clinical practice for long at all. So we're learning that science as we're using it, if that makes any sense. So I don't know if you have more questions based on what I just told you, if that makes sense, or if that just confused you way more, but tell me your thoughts there.
No, it does. And I'm actually in a clinical trial myself. I'm in Toppel.
Yes.
So I have a lot of contact with the doctors there, and I've spoken to them about these specific questions. And so we're going to continue to do when my daughter or I have a transmitter that's about to expire, we're going to pop it on my son just to kind of see until he rips it off, which is what he usually does. Just to kind of see where his blood sugars are at. And then pediatrician is having us repeat his A1C every 6 months. So like you said, it's like knowledge is power, like as much as we can gain, and there's never going to be a definitive answer, yes or no. It's just, it was like a relief that he was negative, then wait, he was positive. And then, so
but at the same time, can you imagine if you just totally were like skipping off into the sunset and then missed the right? So as hard as it must be to be on the edge, I can't even I'd be right there with you. I'd be like, which way do I feel about this? Every day it might feel different, but you're so smart because your instinct told you to check it again, right? Something said, maybe we should screen him again. And it's a totally different scenario to be in, the one you're in now, versus you might have gone into denial and he might have ended up in DKA. Like the way my parents were like, this is a stomach bug from where, right? And left me for days vomiting until they were like, ooh, maybe this isn't a stomach bug, right? But denial is a positive. It's very strong. You can miss things. That negative test might have convinced you to ignore symptoms that you wouldn't have ignored.
Can you talk more about how that decision is made? Because you can be a positive, you can be type 1 with just one autoantibody, but you can't get the potential drug to starve off unless you have 2.
So you remember in the recording how I was talking about the people who don't fit one size fits all, right? So so this is pretty easy. If you look at the ADA standards of care definition, it's changed, right? So I think that the field as a whole is realizing that the science there is evolving. We know about these single we call them high affinity autoantibodies, right? So they are basically very strong indicators that you will continue to progress, even if you don't have like a full panel, because we know not everyone's going to have a full panel. Some very young kids have insulin positive, right? Later in life, more likely to have GAD positive. They're likely to be slower progressors. So we kind of are realizing that these definitions are not perfect. The unfortunate thing is when you do a clinical trial, you have to set your goals for entry and you have to set your endpoints. And so the hope would be that as a field, as we shift into a brave new world where there's potentially more to do, that we'll understand better the science of who needs what when. And I can't, because of where we are right now and who we are, I can't dive into the questions about therapeutics the way that I would like to, but hopefully in a couple months I can. But you're absolutely right. It's not clean like that. It's not like, yep, only people with 2 autoantibodies are going to be the ones to benefit from anything. And the people who have 1 who are really clearly, declining their beta cell function won't. We don't know that. We don't have that information. So you're absolutely right there that it's a suboptimal definition. Fortunately, though, the standards of care say in stage 2, maybe 1, maybe 2, maybe not 2, right? And the other amazing thing is in stage 3, when you've had it for a while, you might be negative. There might be nothing there for your immune system to be interested in going after. So it might all simmer down. And so you might actually not have positive autoantibodies and at a later date, which drives doctors nuts because we go back sometimes years later to prove for some people that they're type 1 so they can justify having a pump and coverage for it. And then they're missing. And we're like, well, you're definitely type 1, but the blood markers are absent. So it's fascinating science, but you're absolutely right. The definition is somewhat arbitrary because that's the way the trial is designed. But I think in the real world, we know that the data supports that there's going to be a very heterogeneous group of individuals. Some of them will not be multi-positive. Some might just be single positive, and they're going to progress to type 1. And I'll add one more statistic. There's some people who are negative for autoantibodies, clearly type 1, clearly, like not even a question clinically, but we probably just don't have the test. They probably have an autoimmune process that they're forming the antibodies that we just don't have the assay to measure yet, but the T cells are clearly killing off those beta cells. And that's a very interesting thing. And there's some clinical conditions where you just can't form antibodies, right? You just have low antibodies for everything. They get a lot of infections and a lot of other, risks associated with that, but they will fool you because they will be negative as well on an autoantibody test because they just don't form a lot of antibodies in general. So there's all these caveats. Nothing is straightforward. If someone's telling you it's like, oh yeah, this is how it is, chances are they just don't know all the data. So, but yeah, Amanda, I'm so sorry that you're in that question, but you are like the reason why we're all doing the studies and looking, because we have to get better. We have to refine our knowledge and figure out how do we find people in earlier stages and what do we do about it. So,
well, thank you for answering all the questions. And I'm sorry I had so many, but
no, that's perfect. They were great ones.
Yeah. And I think, just like we said in the video, if we are trained healthcare professionals that have diabetes and we don't get it right every day, it should really make the point very poignant that diabetes is not a very simple thing. And it's the same with the diagnosis process. And, maybe this is something that COVID helped us too, right? Like experiencing a pandemic and seeing the science,
Yeah.
First they were like, no masks. Then they were like, oh yeah, we should actually do that. It's trial and error, right? And that's what diabetes is. And that's science. That's how it works.
Yep.
So
science is always asking questions and then figuring out the next question to ask, right?
And then repeating the result,
Exactly.
Okay, so the other questions that were in there, thank you so much for that, Amanda, was should people without a family history be screened for type 1 diabetes?
Yeah. Listen, 90% of the new patients that come to us don't have a family history. And those are the ones who are the most likely to go into DKA. Right. So because they just don't, like me, their families didn't know what to expect, what this was, what to do. So my hope would be that one day we'll have something that's not so burdensome, but that we could roll out to every person because, geez, 1 in 300 is still a lot of kids. So, I think the questions are always, risk versus benefit, how much blood, how much time, the anxiety, the counseling, do we have enough people to understand the information, right? Like there's practical questions behind that. So right now the guidelines support screening family members, but I think we're going to see that change because the whole field is changing. So yeah, I believe we should screen everyone because I don't like meeting anyone in the ICU to diagnose them in stage 3. But yeah, I think if you wanted to answer that question, you could. Type 1 Detect allows you to order the kit. You don't need a family history to order the kit. So you could go ahead and answer that question if you want to answer that question. So
I know. I think I'm going to order it for our daughter. That's
not
just to do it.
Yeah.
And then, Michael, did you have a question? I see you unmuted.
Yep. In the general public, the one question I'm going to get is, what is the cost of the kit?
Yeah. So, the Jdrf kit you're talking about?
Any kit that can determine the scope of what we're reviewing.
Yeah. So, okay. Yeah, no, that's a good question. It's a little bit nuanced because, it depends why you're screening, right? Like, did you go to your doctor with a high blood sugar? Maybe not yet stage 3, but it was abnormal. And your doctor was like, maybe we should send those autoantibodies and maybe do blood work. If you were an adult, they might go straight to phlebotomy to do that. Most of the time it gets covered by insurance, hopefully. And those tests can, potentially be a little bit more expensive, maybe on the order of, $100 or sometimes a couple $100. If you have a high deductible plan, you might see a portion of that. So those are always things to talk through with your doctor, right? Because every plan is different. The other thing is the Jdrf kits. You can order those online, and those are a nominal fee. Like I think it's like, if you say you have financial hardship, about $10, and truly probably most of us have financial hardship with diabetes because it's just an expensive disease, right? But then if you didn't, it's probably on the order of like 50 some odd dollars. So, it's expensive, but if it's something that's keeping you up at night, you're going to find the $50. Yeah. So
that's part of it. Here's my other question, and I'm sorry if this is a naive question, but
no worries.
let's say someone does this test and they see that they've got the 2 or 3 positive antibodies.
Yeah.
Okay. They've got the high risk.
Yeah.
Is there a lifestyle change that has been documented that can help them prolong or maybe even postpone or eliminate the chance?
Based on the
action. I'm always a data drives action. And so I'm always looking for, does my action mean that I'm ready for it? Or does my action mean that I could do something to prevent it?
Yeah. No, that's a good question. There's a lot of studies going on sort of looking at, if you reduce the amount of sugar in your diet or you reduce your glycemic load or your glycemic index, I think those of us living with type 1 know, right, that if we kind of go lower carb, lower sugar, those numbers on the tracings look a little bit easier. And I think that there's a reason to think that the hypothesis that changing your diet might help the functioning of your beta cells. The obvious answer in the literature that I could give you is that children who have higher like BMI or weight for length, right, tend to progress a little bit faster. And that's probably some of that stress on those beta cells, but not a direct example necessarily of that. Is there anything currently, like today, for you to do to completely thwart that process? No, but I am hoping that that will change. So, yeah. So you can get the answer. It's going to take you a little bit to get into a peds endo. It's going to take you a little bit to get staged. And hopefully by the time that's all done, the world will be a different place. So,
yeah. I mean, if you're going to get diagnosed, like we said, it's like it's no time like the present. I don't know. Yeah. Right. Yeah. Not that anyone wants to join this club. And I'm sorry that you all just joined it, Amanda.
I know.
And actually, I was going to tell you, there is a study going on for family members who have for families who have like multiple people with type 1, and it's in Utah. So I'll put the link in the chat so that you can sign up, because they're trying to figure out, sort of why these clusters happen, because there are like definitely families that we know who have, parent, kids, or like multiple siblings. And then there are people like, Diana and me who we're it in the family.
Yeah.
So.
And Michael, and the evidence is clinical trials. So there is something to do there.
Thank you. I hadn't heard of that trial. I think the tricky thing is, like, for myself, I had no problem getting into the trial that I'm in because I'm an adult.
Yes.
The age range for the type 1 trials in littles are higher. From what I'm noticing in trials I'm looking at. My daughter's on a device trial right now, which has been fine. It's actually, it's PDAP. It's for under 5 for control IQ. So they wanted littles, but the other one, so I'll be interested to see that one in Utah, if that trial, has that age limit because of the younger age of my son.
I don't think it's, I was gonna say, I don't think it's actually like a
intervention
trial. Yeah, I think it's more like they're collecting data, and it's probably that they're collecting samples to keep them to study, like when Dr. Miller was saying, when we get other assays, when we figure out, oh, this other gene is related to beta cell destruction, et cetera. So
like, could you send a panel, right, on people, like do a buccal swab, send a panel and say like, this family is going to be a cluster. We really need to watch, closely, or what, hopefully one day we'll get to the point where we have that degree of personalized care. So
yeah, or it'll show up on the 23andMe.
Yeah.
Like, yeah. Yeah. And then there's one more question, which was, we talked a lot about kids. What about screening for adults?
I have a bias there. I always talk about kids, but yes, adults. I mean, that's the thing. Like even TrialNet caps off at a certain age, right? So this is like a brave new world as far as data, because we have people in their 90s who get type 1. We have people in their 70s who get type 1, right? We don't know if they were like positive their whole life, or if they seroconvert in their 50s and then develop type. We just don't know. And so that is an area where we're studying. And if they want to be screened, I mean, I truly think, these are kits that are available if they want to be screened, if it's bothering them enough that they feel the need. I mean, people who have family histories maybe of autoimmunity, it would make more sense, right? Because most of the people who didn't have a family history of type 1 typically still had a family history of some autoimmunity. Like when you dive into family history, they're like, oh, thyroid or this or that, there's that like hint of it, which kind of tips you off a little bit. But yeah, it's available. So I'm not going to say no, but at the same time, most likely it's going to be negative, right? That the stats are in your favor. And if it isn't, then we're all here on a call together talking about it. So,
I mean, like you mentioned, how most people that are diagnosed don't have a family member. And so, it's kind of like, they don't know that they need to know, and we don't know how to tell. So, until we get something where it's, standard, easy, it's just going to be pockets, if you will.
Yeah. People who thought about it or read about it or, what have you. I mean, that might make a difference. It might be that they're the ones who are going to avoid something that was coming their way. You just don't know, but hopefully it'll be standardized. That will be the hope, is that it's not sort of a haphazard process. Like for all of us, it was probably very a haphazard process. Right. I
was diagnosed Labor Day weekend. They didn't even call my parents until like the Monday. So it's like my birthday, I had cake. It was fine.
Like the labs were just sitting there.
Yeah, exactly. They're like, oh yeah, our blood sugar is 680. Huh.
Goodness.
I was in the hospital 40 years ago this month.
Oh, wow. Congratulations.
Happy anniversary. Yeah. Were you in DKA? I won't ask.
No.
I don't want to put you on the spot.
I wasn't.
No, my grandmother had it. My mother was aware. Certainly at that time, there was nothing more than just knowing the symptoms. And I was fortunate enough that I had symptoms that were clear enough to my mom that she took me right to the doctor.
Yeah.
And she had me diagnosed before we got in the office.
Yeah.
Um,
and that's the benefit that a family history gives you, right? Because the half of people in DKA diagnosis, that really applies to people who don't have any idea, right?
Correct.
The data is less pronounced in those of us with a family history, but like I said, denial is a powerful thing. I mean, Amanda, I'm like so impressed by you because, and that's why I didn't screen my kids, almost because I will, but it was because I wanted to keep my wits about me. It was like, I almost knew that if it was negative, I'd be like, woo, and then if it changed, I'd be like devastated. So I'm just sort of like, right.
I mean, my kid was negative, but every time, like he had a GI bug right before we did that recording, and he was like not eating. And I was like, oh man, like what if this kid, like,
what if
you know what I mean? Because they say like, oh, it could be the flu, and yeah, 76. I was like, thank you. I'm not ready for this yet. Like, even if it happens, it's fine, but not now.
I know,
and you'll handle it just like everything, right? You roll with it. I think that is something diabetes teaches us early on. It gives you a lot of humility because it doesn't always play by the rules, unfortunately.
No. And then your CGM might say one thing and your finger stick says another thing. I mean, it's constantly, we're like great data detectives over here because we're always like, do I trust this number? Do I not trust this number? You sort of play that game, which is why I love it, Amanda, that you were so spot on with all of that, because I mean, that is the mindset that you learn so quickly with diabetes is like, how do you assess all of these different variables and put it all together and piece together this puzzle, which you did very well for your whole family. So,
yeah. My son's going to be disappointed because we're going to Friends for Life. And let me see my countdown, 40 something days. Yay! We have a little Mickey countdown over there. And my daughter and I will have the same bracelet and he will have a different bracelet. So
I talk about this all the time. Yes. It's like you're disenfranchised, right? It's like,
he's gonna be left out. And then my daughter also has celiac. She was diagnosed with that after type 1. So she has 2 bracelets coming her way.
Oh, she does.
So
she gets her own buffet.
She's very excited. In our family, it's like an honor to wear robots. It's, and so it's our first time, but we're very excited to be going and to be around other people who understand this and understand these fears and, have these same kind of questions.
Your tribe, we get you.
Yeah. And you'll meet other families that will have the multiples, and a lot of them are there.
Find me. I'm going too. So find me.
You'll meet those people and you'll see them there and you'll just get reinforced, but you are the role model right now. I mean, it's one thing to be thrown into this, but just listen to yourself and what you are trying to learn and what you're putting into place. That's outstanding. I don't have any worries for you or your family's future.
I'm telling you, Amanda,
it's been kind of a crazy time. So thank you.
Yeah. I was going to say, take care of yourself too. Like mental health. I mean, I think that's the biggest, it's not the biggest piece, but it's a large part of living with type 1 for 40 years, I'll be at 32 years this year. And Diana, I think you're at 25. No.
I'm coming up on 30. I stopped counting. I forgot how old I was in medical training for like a decade. I was like, I'm somewhere in my 20s. I don't know. But yeah. So now I'm in my late 30s. So yeah. So we're coming up to almost 30 years. So
yeah, it's that resilience, right?
Yes.
You have to, and it's just like anything in life, right? Like sometimes you're like, oh, look at this. I got 98% in range. And you're like, you got to celebrate those wins because sometimes you just kill it. And sometimes you're like, I'm 300. It's okay.
And Amanda, for what stage you're in right now, you have to have comfort that, the ambiguity is there because it's there. Just accept, that you don't know necessarily how things are going to play out, but the fact that you're aware of it is a way better place to be in than, just being blindsided, which potentially could have happened. So,
although my daughter did get to ride in an ambulance when she was diagnosed, and I think my son will be real upset if he doesn't get to ride.
We'll have to ceremoniously arrange a local rig to go for a joyride.
do a joyride just because we'll diagnose, just like Michael, we'll diagnose him before he gets there, but he needs the experience of the ambulance.
Oh, I bet the fire department would do that. I bet the fire department would do that. Yeah.
Totally.
On a chill day.
Yes. Yeah. Post-COVID.
Well, thank you guys so much. This was perfect. This is exactly what we wanted to do. We wanted to, get the information and then have some good, meaningful conversation, because, that's what we all need, right? Is the human side of all of this.
And thank you for participating in clinical trials. I mean,
yes.
Truly, thank you. You're changing the world for literally everyone. So thank you for that. I'll see you at Friends for Life.
I know. We'll see it. I mean, it's like a month and a half. I'm like, I may or may not be working after this call as well. I don't know. It's fine.
Excited to see all of you and meet all of you, but someone's awake upstairs and they're not supposed to be. So I've got to go. But
I understand.
See you there.
Night.
Totally.
And we'll see everybody soon. Thank you so much. And thank you, Diana.
Oh, my pleasure. Bye. Great seeing you, Michael. Thanks again.
Bye, everybody.
Bye,
Good
Marissa.
night.
Good night.